Welcome to this edition of Urban Health Beat 2.0, the podcast. I'm your host, Marilyn Harris Davis, and
I'm Dr. Garry Jennings.
So today we have a very special edition of Urban Health Beat. We are going to be talking about pain management, although it doesn't sound really good, but by the time we finish the show, it'll be good.
It'll feel good.
It'll feel good. It'll feel good. You'll feel better. Dr. Jennings has a practice that is called
QOL, pain management.
QOL. QOL stands for quality of life. And quite frankly, he really works hard to improve the quality of life for people who have pain from all circumstances. It could be sickle cell, it could be your knees getting replaced, it could be anything, right, Dr. Jennings?
Back pain.
Back pain is huge.
Cancer, patients with neck pain, pain in general, yeah.
Yeah. You know, actually, I was thinking about cancer, not that I want to think about that a lot, but what kind of pain comes from that?
Well, there are several types of broad categories of pain that we look at. One of the categories is called nociceptive pain.
Called what?
Nociceptive.
Nocio. Can you spell it for me?
Nocioceptive.
Okay.
As opposed to neuropathic pain.
Neuropathic being in your
pain that
nerves?
arises from a nerve.
Oh, okay. Mm-hmm.
And nociceptive is pain that arises from everywhere else. So patients with cancer and who have pain associated with metastases of their cancer, usually, will have...
And metastases is spreading.
The spreading of the cancer will have pain that's associated with both. If the tumor invades a nerve, you're going to have a different type of pain than if a tumor is pressing on, say, it's in a bone.
A bone?
You have a different type of pain. And so those actual two types of pain actually feel differently, as a matter of fact. Neuropathic pain, which we see more often in diabetes, because diabetes is more prevalent, is a burning, stinging type pain, as opposed to the pain that you get with a headache or a fractured leg, or you bump yourself, and that's the nociceptive pain.
Is that stinging kind of pain like a consistent pain, or is it coming and going? Generally, because I'm sure it's individually.
The neuropathic pain is more likely to be a constant pain.
A constant pain.
And the nociceptive pain is, you fracture your leg, it aches, it hurts, but when you step on it or move it, it hurts more. If you have the headache, that's nociceptive pain also.
You have a headache associated with it?
I said nociceptive pain is a type of pain. It's a throbbing,
oh, it's like
pain.
A headache, like
a
throbbing headache.
That's a way to identify it. Yeah.
Interesting. So how do you treat that? I mean, it's not that you could treat the cancer necessarily, but but folks come to you to treat the pain, to relieve the pain that's associated with that illness, correct?
Right. When you see pain that's associated with cancer and a malignancy or a metastasis, you have, again, the nociceptive pain, and you'll have that's associated with the inflammation around that particular tumor and what it's causing and how that causes pain. And if that tumor is also invading a nerve, you'll have the burning, aching, the burning, stabbing pain. So you would describe aching, shooting, stabbing types of pains. And so there are different treatments for both of those. Pain that arises from a nerve usually doesn't bode well with opioids. They don't work together well. As opposed to pain that you have, the nociceptive pain, that opioids work better on that. So what happens, you'll see a patient who will be on maybe an opioid and a pain medicine that will control nerve pain. And a lot of those medicines are the anti-seizure medicines. So, because seizures are caused by abnormal impulses of a nerve, the brain is just a big nerve.
Okay. I thought seizures were caused by epilepsy.
Well, that's a disease.
Oh, okay.
But the actual seizure is a abnormal nerve firing.
I see.
And so that's what nociceptive pain is. I mean, neuropathic pain is that abnormal nerve is firing. And so those same type of medicines that would quiet the brain will also quiet that particular nerve and help reduce that pain. But that's very difficult to treat nociceptive pain. whether it's with cancer or whether it's associated with diabetes, which again, that's more commonly what we'll see in a diabetic.
So, with speaking of opioids, I know that in today's world, they say we have an opioid epidemic, and several insurance companies are not necessarily reimbursing physicians for prescribing opioids because they tend to be abused. Can you speak to that a little bit? But opioids are a pain relieving modality, correct?
Right. They say we have an opioid epidemic. It depends on what neighborhood you live in. In my neighborhood, we've had opioid epidemics for the last 40 years.
Wow.
I think that essentially opioids are medicines. They're valid medications that can be used to treat pain if the pain is correctly diagnosed. Again, we talked about pain from a nerve versus pain from a broken bone.
Oh, well.
Actually,
that hurts.
So that's nociceptive pain,
Yeah.
and that's where you would get an opioid from, as opposed to a diabetic neuropathy with the burning, stinging feet. That you would not get an opioid for that because it doesn't work very well for that. I think that one of the things that we have, if there is an epidemic, is because doctors who were not experienced in managing pain were just giving out a lot of opioids just to give out opioids. And so that's why we have pain specialists. Actually, most of the medications that are being misused are given for acute pain, not chronic pain, which is what we talk about when we talk about pain from diabetes, or most of the patients I see are chronic pain patients, as opposed to...
So acute versus chronic. Tell me the difference.
Okay, acute pain would be, I just had surgery. 3 days from now, I'm going to be better. Chronic pain would be, I broke my back and I have an extruded disc, and I'm going to be in pain for 6 months, a year, 2 years, 5 years, 10 years. So it's a length of time. So most of the opioids that are out floating around are the opioids that we get we give for acute pain.
So sometimes you might prescribe, and I'm not saying that obviously you do this, but sometimes a physician might prescribe an opioid for acute pain, meaning like I broke my ankle and the pain is continuing and continuing. But then sometimes the pain goes away and they still have the prescription and they're selling it. That's what we're talking about today in the world?
Yeah, because your ankle heals, and so maybe after the fourth day, your pain, again, we have different medications. Opioids are just one. So after the fourth day after a fracture, you may do well with Tylenol. You may do well with a Motrin type medication, a naproxen. But if I gave you, as your surgeon gave you, or your primary care doctor gave you 100 opioid pills, well, you only need 3 days worth. So what happens with the other 97 pills? Well, they sit in your medicine cabinet. Your grandkids get it, or you decide to sell it, or your son come home and get it, or they break in your house and get it. You have all these extra pills floating around, and then that's what we see a lot of. I mean, what's happening now, and you started the whole conversation about the issue of opioids and the epidemic, is that a lot of these extra opioids are floating around. Now, they're pinning it on a lot of the pain management doctors. Not in this particular state, where there are states and there are problems with doctors of all ilk. But mainly 40%, 50% of these medicines that are out there are post-operative medicines that have been left over.
After someone's had a surgery and they're better. So you were saying that there are other types of pain relieving medications other than opioids.
Right.
And I know that you are, and correct me if I'm wrong, because you always correct me. Okay, and I'm not usually wrong.
I'll hardly ever correct you because you're never wrong.
Yeah, right, exactly.
As far as she says.
But yeah, so you are one of the pain management physicians who, again, you don't prescribe, but you can recommend the use of medical marijuana for the relief of pain. Is that correct?
Right. We're looking for other modalities other than opioids to help with pain. But, it doesn't mean that opioids are not going to be used. It's kind of like the more help you have doing anything, cleaning your house. If you have someone cleaning the bedroom and someone cleaning the kitchen and the living room, then at the end of the day, you're not so tired. If you had to clean it, then you would be very exhausted at the end.
No, if I had to clean it, it would be pretty much a disaster, but it's okay, okay. No.
So by using a lot of different types of medications,
Yeah.
you use some opioids, some anti-seizure medications, some antidepressant medications, some medications we call non-steroidal anti-inflammatory meds like Motrin and Naproxen, those type of medicines, or Tylenol.
Motrin, Tylenol.
Right.
Excedrin?
That's just Tylenol.
Oh.
So if we use a lot of those medications together, we don't have to use a lot of any one particular. And what we're seeing now is that marijuana can help with some of the neuropathic pain. Doesn't mean that it's going to be the only medication that you're going to use. And again, what we're learning about, I am hesitant because 10 years ago, opioids were the fantastic thing, and all of a sudden we have an issue with it. And 10 years ago, Celebrax or Motrin was was a great medicine. Now we're finding out it causes cardiac disease and things like that. And so now we're using medical marijuana. Right. So let's see what happens in 10 years. Because it seems like it's a cure-all now, and it just just have as many different types of issues. Or have side effects. I mean, if it works, if anything that works has a side effect, gee whiz, you can drink too much water.
No.
Yes, you can drink too much water and have water intoxication.
No.
Yes. No. Yes, you can. Yeah, because you dilute the salts in your body, and now you have water intoxication. It swells in your brain.
So wait a minute. Okay, let's just put a pin in this.
Okay.
So you can have too much water because it dilutes the salt in your body?
The salts in your body, yeah.
Salts, S-A-L-T-S?
Yes, salts, different salts.
Different salts?
Sodium is one salt, potassium is another salt, magnesium is another salt. And those things are diluted. If sodium is diluted, then your brain swells. If potassium is diluted, then now you have cardiac arrhythmias. If the magnesium...
Or cramps. Let's not talk about cardiac arrhythmias.
Or if the magnesium is diluted, then you have cramps. So you can drink too much water. You can have too much oxygen.
No.
So things that work, anything that works, has a side effect. So marijuana, people say it has no side effect. Yeah, it does. It has a side effect. We either haven't discovered it yet, or people aren't talking about it like they didn't talk about the opioids until it spread to other communities. Oh, it was always a problem in my community. Maybe not yours, but we always had a problem with opioids.
And our communities are similar, but you're from New York, so.
Yeah.
But yeah, that's interesting. So too much of anything. So everything is in moderation. But yeah. So tell me about how. And I don't mean to belabor this point, but the process with the recommendation for utilizing marijuana, because we've had folks on our show, Urban Health Beat 2.0, in the past that talked about the benefits of medical marijuana for various chronic conditions.
Yeah, that's what we're looking at.
I don't know, you tell me.
Well, some of the conditions that the state says that you can get it for, and that's what we're looking at. Some of those conditions are post-traumatic stress disorder, anxiety, you put those two kind of together, migraine headaches, weight loss, chronic pain, nausea, vomiting associated with cancer, glaucoma, those types of things. And you have to have those particular categories. You can't just say, oh, my stomach hurts, I want some marijuana, because there's certain criteria that must be filled before your doctor can approve it. Right.
Approve that treatment. Well, I have to tell you, I mean, I think we've had some folks on the show, and I went into a marijuana dispensary. It was jam-packed with people. I mean, I don't know. I mean, I'm sure that they have chronic conditions that their physicians are prescribing for, but it was jam-packed. And I don't know, but I agree with you in that in 10 years it's just like with microwaves. I always say this about microwaves. I really don't use a microwave oven that much. Well, I really don't.
Well, because you
I might have used
don't.
it
Yeah,
once
but you
today.
don't cook. You don't use your regular oven either.
Shut up. Yeah, well, then there's that. Then there's that. But yeah, because I mean, I know that it heats the food from the inside out. I guess that's what I understand.
Yeah.
But there's got to be something unnatural about that. You know what I mean? So I'm thinking the same thing when it comes to this marijuana, or like they're discovering with opioids. It's like, what? You know?
It's given enough time, what we begin to find
So
out.
we can do the studies. and
Yeah,
that's-
but the thing about it, no studies are really being done on marijuana because it is illegal federally, and it's very difficult to do a study on something when you're getting monies from the federal government to do something that's federally illegal.
Okay, well, okay. So it's federally illegal, but on the state level,
But
on the
most,
state level, from
it's
state to state,
state,
it can
it's-
be. But the feds need to catch up with the states.
yeah, the funding, comes from NIH, and that's federal, or from the federal government. You get the monies to do the studies.
I see.
And then there are no big drug companies out, big pharma out to fund studies either, which I wouldn't trust anyway.
Well,
Well, the studies are biased. If a big company wants to say my pill works,
well,
then they're paying you millions and millions of dollars. Are you going to stand up and say, no, it doesn't? That's pretty difficult. As a matter of fact, most of the studies that are done, and I know we're getting off on a little tangent, but most of the studies that were done are going to say, does my drug work better than nothing, which is placebo? That doesn't say, does it work better than old, the medicine that's been out for 80 years?
yeah.
But that has worked. It works better than nothing. So, that's a new drug that's out.
Yeah. So just to get back on track, let's talk about sickle cell. I know that you do work with sickle cell patients, and
Yeah.
mostly African Americans have the sickle cell trait. Is that
Well,
the
mostly
thing?
people from around the Mediterranean area will have, and parts of India will have a sickle cell trait because of where we're located, and there are a lot of people of African descent in the United States. You're going to see that mostly amongst African Americans.
And what is that exactly? I mean, it's what, a mutation? What?
Yeah, sickle cell is a mutation. It's actually, sickle cell trait is very beneficial in areas of high malaria, where malaria is
definitely
endemic.
African.
So, or anywhere in the Mediterranean or places in India, but we just think about that. And so, where malaria is, because the sickle cell trait changes the shape of the red blood cell, which is usually like a disc, it changes to like a banana shape. The parasite can't live in it very well. So those people will survive malaria, where someone without with a normal red blood cell will come down with malaria and possibly die. So the people who have the trait have an advantage. However, people
The
who
trait is shaped like,
a banana,
A banana.
yeah, kind of discoid shaped, kind of abnormal.
right. and
Now
then
with
the
sickle
regular
cell,
blood cell
it's like a plate, looks like a plate,
Okay.
a saucer. Now people with sickle cell, their red blood cells change so much because they have the total disease, not just the trait. Theirs change so much that the red blood cells begin to stick together. And so now they get little tiny blood clots all over their body, and then that leads them to having pain. And so we'll see these patients who have sickle cell crisis. And that
meaning
can,
the pain is excruciating.
it's
at that point.
excruciating pain. And so you can have a little tiny baby who has sickle cell crisis, and now you have a baby that
So
has
what do
this
you do
chronic
with
pain.
those, if those blood cells are causing pain? Well, obviously you're a pain management
Yeah.
physician, so you treat that. So what, you quell the pain, or do you take out the blood? I'm not clear.
Well, we do a number of things. What we do personally is that we would hydrate the patient. That way the red blood cells won't be so sticky and stick together. And then also what we do is that we reduce the pain, because what happens is that anxiety can actually cause a crisis. And so by easing the pain, we reduce the anxiety that the patient is having, and that helps calm the crisis down. So those patients essentially
So you
get,
just calm them down?
they get oxygen, one, they get pain relief, two, and they get IV fluids to help flush the system and keep everything moving.
All right, so you can get IV, and then when you say help everything move, I'm thinking, I'm picturing like with people who are diabetic and they get, when they have their blood cleaned out. I'm sorry, I'm forgetting the term. Tell me.
Diabetics get their blood, they don't get their blood cleaned out.
No, yeah, they do.
No, not to my knowledge. No. You're thinking of,
Okay,
maybe,
well, I'm just, look, okay, so.
maybe you're thinking
You went to too
chelation,
much school.
chelation therapy in patients who have lead poisoning?
No,
Are you talking about patients who have renal failure and have to have dialysis?
that's what I'm talking about. And isn't
Okay.
that getting your blood cleaned out?
Yeah, you're
Yes.
getting yeah, but that's not
See?
diabetes, that's renal failure. That's why I was confused.
I'm sorry. Oh, okay. I'm sorry, I thought it was diabetes.
Patients with diabetes have
Well,
an
they have-
increased
they have
risk
to have
of
insulin.
renal failure.
But renal failure, it can lead to renal failure.
Yeah.
Okay, sorry. But anyway, so, with that being said, as we were talking about sickle cell, so you don't have to have dialysis or can you have dialysis to get rid of those
No,
bad red
because
blood cells?
what you can do is have a blood transfusion,
Okay.
which would actually give you more normal blood than the sickle cell blood. And if one cell outnumbers the other, then that will tend to reduce the crisis.
Oh, all right, okay. So what are some of the other modalities that you use? I know that you do some acupuncture. We were going to do acupuncture today, and we will, stay tuned, we will be doing acupuncture. I'm not going to have Dr. J do it, but on me anyway.
Well, because it's called pain management. Unfortunately, it's not called pain cure. We're not at that point now. So we look for different modalities other than medication. So we did talk about four broad classes of medications, but there also, we do nerve blocks to help people with certain types of chronic pain. And we do...
How do you do a nerve block?
Well, say for instance, sometimes nerve blocks are diagnostic. For instance, if you said to me, you put your toes in a box and said, my toes hurt, which one? You couldn't tell me, I couldn't tell you either. But if we numb each toe, when I numb one toe that wasn't hurting, was causing the pain, you go, hey, my foot feels better. So that's a diagnostic use of a nerve block.
Oh, I see.
Sometimes we'll
Blocks
give,
all the nerves,
yeah.
essentially.
And then what we'll do, sometimes we'll put medications, and those medications will have to be deposited near a nerve to help reduce swelling and inflammation around that nerve. Remember, we talked about abnormal nerves in the beginning. So if we can give a medication right to that particular abnormal nerve, then we don't have to give you a pill, which would be a much larger dose, because that pill has to go over the entire body, except to that one specific point. So those are some of the reasons that we use nerve blocks. And we're trying to move away, again, from medications to those blocks. But again, we're talking management, and we're not talking cure. We're not at that point where we're talking
So
cure.
that's why your practice is QOL, pain management, as opposed to
Pain cure.
pain cure.
Yeah.
Right, it would be yeah, well. So how do people get in touch with you if they...
Well, my phone number is 410-578-0730. And you can have your doctor call that, because what we do is that all our patients are pre-screened by their physician. You can't just walk in and say, my neck hurts, and become a patient.
Oh, really?
You have to come from your physician.
physician.
Will have to be referred from your physician.
To say that they
Yeah.
need pain management.
Right.
From your general practitioner.
Yeah.
Yeah.
Or the surgeon who
Or
does
whomever.
something.
Yeah.
And then what we'll do is that we'll look at your records, and we decide if you're someone that we can help. We can't help everybody.
Yeah, well, everything doesn't work for everybody. And you're also an anesthesiologist, right?
Right.
I always tell people on the show, I'm not crazy about having a co-host that puts people to sleep for a living, but...
I put you to sleep for free. I charge you to wake you up.
Yes, indeed. And he wakes everybody up, as far as I know. QOL, pain management. You're located right in Baltimore City,
Yep, right in the city.
Hilton Street. So if you're in pain, go to Dr. Jennings. But he is my own personal pain. So, Doc, I'm going to ask you a question. You probably know the answer to this, because you know that we say that laughter is the best medicine. So, why did the tomato blush?
I haven't the faintest idea.
Because he saw the salad dressing.
Okay.
Okay, you can laugh. Feel free. You've been listening to Urban Health Beat. I'm your host, Marilyn Harris Davis. Here with my co-host, Dr. Garry Jennings, who is also my very, very special guest today. QOL Pain Management, thank you so much. I've learned a lot. Till next time, remember, your good health is a work in progress.
So work it.